This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be undertaken only with prior written consent of the AARC. Copyright 2012, all rights reserved. My name is Bill Dubs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on pulse oximetry, advances in technology. At the end of the program, you should be able to you should be able to discuss the utilization of pulse oximetry technology and screening protocols. Discuss the utilization of standard pulse oximetry technology for the monitoring of patients at risk for negative outcomes in the hospital setting. You should be able to review the utilization of standard pulse oximetry and screening protocols for congenital heart disorders and obstructive sleep apnea that are scientifically supported. You should be able to review recent evidence in the use of co-oximetry in the hospital setting to facilitate processes and describe cerebral and regional oximetry monitoring that is being adapted and implemented in many institutions by respiratory care in various patient populations. I do apologize. The objectives that are on the screen were not the correct ones. The ones that I read are the correct ones. I am pleased to introduce Timothy R. Myers. Tim is a registered respiratory therapist holding an NPS credential. He is the immediate past president of the AARC and a past chair of the AARC's neonatal pediatric section. He's currently employed as Administrative Director, Women's and Children's Respiratory Care and Procedural Services and Pediatric Heart Center at University Hospital's Rainbow Babies and Children's Hospital. He is also an adjunct assistant professor of pediatrics on the faculty of Case Western Reserve University School of Medicine. Both institutions are located in Cleveland, Ohio. Tim is the author or co-author of many peer-reviewed papers listed in Index Medicus and is a frequent presenter at state and national scientific conferences. Mr. Myers discloses that he has no conflicts of interest related to this presentation. Brand names of products may be mentioned only as examples of technology. Tim, welcome to the program.
Thanks, Bill, and thanks to everybody else out there joining us today to talk a little bit about oximetry. So we're going to go ahead and jump into this and get started. These are the basic areas or generic areas that we're going to focus on. And really what we wanted to try to do today is really to talk about new concepts or potential opportunities in non-invasive monitoring for the RT community. Some of those have been out there for a while, but it's potentially a way of looking at utilizing some of that technology that we all have in different venues and some potential new technologies that are arriving onto the scene and how those are being integrated in the clinical setting. One of the things I like to do is I always like to take a look back before I move forward, and a little bit of history about oximetry is listed here on this slide. And basically what the short and sweet of it is that there's about a 40-year developmental history starting in the early 1940s with a variety of folks that took an interest in oximetry, and really kind of arriving on the clinical scene in 1972, if you will, by Takis Agiogi. And really that was where we started seeing some of the more scientific basis for pulse oximetry coming into the scene. And in fact, in an article written in Anesthesia and Analgesia back in 2007, John Severnhouse actually concluded that Takis Agiogi actually was credited with being the individual to demonstrate the clinical utility of pulse oximetry from a quality and safety standpoint. You can see on there that he felt that the introduction of pulse oximetry coincided with a 90% reduction in anesthesia-related deaths. And that kind of really got us rolling as looking at this device as a monitoring tool and potentially the safety and efficacy. And I think there's some interesting things that have come out since that time and some new technologies arriving on the scene that may help us do some additional monitoring in a non-invasive situation for patients in an overall quality and safety standpoint. Again, if we look at the basics of pulse oximetry, regardless of what type of oximetry we're going to talk about here today, we're really kind of focused on the Beer-Lambert law, which basically simply states that the concentration of an unknown solute in a solvent can be determined by light absorption. And we all know that there are different types of light absorption based on hemoglobin, be it oxygenated or deoxygenated, that there's interference by separating out this pulsatile signal. We get heart rate by measuring cyclic changes in light transmission. And basically there are four main types of hemoglobin that we're looking at from this light absorption technology, if you will. Deoxygenated, oxygenated, carboxy, and methemoglobin. And most of us are probably pretty familiar with those as we run across them fairly regularly in a clinical setting. Some of the vital statistics that we're really kind of focusing on in some of the literature and data out there is that pulse oximetry typically correlates very, very well if the true saturation is somewhere in the range of 70 to 100%. And in fact, when you look at standard deviations, it's within 2% of the actual saturation if you would take it to a coax blood gas machine 68% of the time. And if you want to get really out there into the deep standard deviations, plus or minus 4% is true 96% of the time. Now, there have been a number of studies out there over the years that demonstrate that a fall in your pulse oximetry often precedes any change in any other vital signs. So you'll see that pulse ox drop out before you'll see any change in blood pressure, heart rate, or some of the other parameters that we measure as vital signs on a regular basis. But there is a key component here, and that's really the difference between functional and fractional saturation. So pulse oximetry typically yields a functional saturation, which is basically the ratio of oxygenated hemoglobin to the sum of all functional hemoglobins present. And really it's basically the sites filled versus sites available for O2 to stick to those red blood cells, if you will. And we're going to talk and start a little bit with functional saturation in pulse oximetry, but what we're going to do is kind of flip over to fractional saturation, which is typically defined as a measure by co-oximetry via blood gas analysis, which is the ratio of oxygenated hemoglobin to the sum of all hemoglobins, not excluding any of the not normal or alternate hemoglobins, if you will. And we're going to talk a little bit about that technology in a little bit later in this presentation. So we're going to start off really taking a look at the opportunities to monitor to what I'd like to refer to as minimizing undesired outcomes in the clinical setting. And again, pulse oximetry has been used in this domain for a very, very long time. And similar to that publication from Takas Aoji back in 1972, you're looking at a graphic from a paper published by Tanzer and colleagues in anesthesiology just a few years ago that really looked at the ability to reduce what they felt is rescue events. And a number of years ago, rapid response teams became a very big vogue through most hospitals to actually get the right team at the bedside to minimize adverse events or safety issues for patients. And so this was based a little bit off of some of that rapid response team literature that this group took a look at, really putting patients that they felt were potentially at high risk in certain types of areas of their institution on continuous oximetry monitoring, and really looking at what they could discern from this type of monitoring. And basically, if we take a look over here in the first graphic on the left-hand side, if you will, is that they found a significant reduction, almost a 50% reduction, if you will, that was statistically significant in the number of rapid responses or rescue events that their team was getting called to the bedside for. And this was really based over 1,000 patient discharge, so it was a pretty significant number of patients. And in fact, these authors went on to actually even show in a slightly different format, if you will, a large reduction, again, about 50%, statistically significant, in the number of these folks that actually had to be transferred for a higher level of care into the intensive care unit setting. So again, while we're not out there promoting or trying to propagate using continuous oximetry in every patient in a hospital setting, I think each and every one of us on a daily basis, and we start our day off every morning at 8:45 here with everybody in an administrative leadership role and a lot of our key physicians on what we call a high risk or safety call. And we spend about 15 minutes covering the various areas of the hospital, talking about potential problems, patients that are concerning or are at risk of potential, having a downturn in their clinical events or situation. And so again, I think those patients that we identify and those patients that you identify each and every day that potentially are at risk for untoward events are potentially patients that may be beneficial from continuous oximetry monitoring in this type of situation. And in fact, I'll take you to an area a little bit closer to what I do on a daily basis, which is the neo-peds area, and it really takes a look at those premature infants. And this is a paper just from about a year ago, published in Octave Pediatrics, that really took a look at the critical nature of what we kind of sometimes refer to in the NICU as the sweet spot of delivering FiO2 in those extremely low birth weight infants. And what they basically did is they took a look here at infants that were extremely low birth weight, less than 1,250 grams, and what they were attempting to do is identify that sweet spot, managing their FiO2s somewhere less than 93%, because they felt too much oxygen is not good. And ultimately, if you look at the literature, some folks feel that the sweet spot is actually somewhere between 88 and 93% in these premature infants. And they were actually taking a look at potentially too high of FiO2 versus too low of FiO2 in these babies, and trying to hit that sweet spot to prevent any adverse events or untoward events that they didn't want in this premature population. And what they actually concluded is that pulse oximetry resulted in a significant reduction in severe ROP and the need for laser surgery in these infants by trying to hit that sweet spot somewhere between 88 and 93%. And in fact, we spent a big part of our last year here at Rainbow doing the very same thing with some of our pulse ox technology that we have at every NICU bedside, and really trying to optimize oxygen delivery. Not too much, not too little in a lot of our premature babies, to minimize the risk of ROP, the need for laser surgery, pretty much based off this type of paper. And we actually found some very interesting things. While we were doing a very good job, we could probably do better, and we've actually put an increased focus, which has actually improved our outcomes there. And in fact, if we take a look at the next study, which was published in Pediatrics about 2 years ago, it also looks at this concept of optimal oxygenation, or the sweet spot, if you will, in the premature infant. And what they actually did is they actually did a meta-analysis. And what you can see here on the left-hand side of the screen is a meta-analysis looking at low FiO2 versus high FiO2. And then over here on the right side, a higher FiO2 versus a lower FiO2. And what they really did is they looked at two different time periods. So that's kind of what you're going to see down here in the conclusion, that they said based among preterm infants with a gestational age of 32 weeks and above. Now these are that patient population that often isn't a very low birth weight. They don't necessarily always need surfactant. They sometimes come out and just need a little bit of oxygen or a little bit of non-invasive support to help them kind of get over the hump and kind of get themselves established in the first week or so. But what they found out in this kind of premature population still at 32 weeks is that they kind of favored, based on this meta-analysis, of actually going with a lower saturation or oxygenation level initially, and then after the first week, actually a higher oxygen saturation that they derived. So they kind of kept them in that, what we refer to as that sweet spot, 88 to 93% in that first week of life, to kind of get them stabilized, get them over that hump, get rid of some of that respiratory distress, kind of get the surfactant engines working, if you will, to produce their own surfactant if they weren't quite capable of doing so at 32 weeks or so. And then once they kind of actually stabilized them, they tended to let them sit at higher saturations after that first week, 93% to 95%. If you look at most of those studies, and they found out that produced very, very good outcomes in this meta-analysis of a variety of studies thrown together that favored a reduction in ROP, and then the actual decrease, if you will, in the need for laser surgery. So again, a lot of times meta-analysis produce results that you may or may not see in a clinical setting, and so therefore they went on to say that they felt that a large randomized clinical trial with this should be taken a look at in a more clinical setting, as opposed to relying on the meta-analysis results. But I think it still gives us an indication that there is potential opportunity out there to take a look in the neonatal ICU, despite the fact that we've had the technology there for a long time, at really optimizing how we manage oxygen in those very small babies, or in the premature babies less than 36 weeks altogether. And in fact, if you look, there's still a lot of interest. And again, this goes back to some of those patients at high risk. So this comes from the clinicaltrials.gov website, where there is currently an ongoing study looking at the utility of intermittent spot check, if you will, versus continuous pulse oximetry in infants admitted with bronchiolitis, or is more commonly referred to as RSV. And what they're doing is basically doing a comparison of looking at patients that come in and immediately get randomized to continuous pulse oximetry and looking at a variety of outcomes in them versus those that are just getting intermittent saturations checked with like their vital signs at an every 4 to every 6 hour frequency. And what the trial is set up to do is to really see if there is a difference in these patients potentially at risk being monitored with intermittent versus continuous pulse oximetry. So again, this trial is actually just getting underway. It'll probably be several years, 2-3 years down the road, since RSV can be very seasonal, to really get the number needed to treat and randomize into this control trial before we see results. But again, a lot of interest in looking at using this device in a continuous monitoring standpoint outside the ICUs to actually identify patients at risk and to try to minimize safety or untoward events that may occur. So that's kind of looking at the technology that we've had out there for a while, and potentially some new areas or some new items in the literature that may be of interest. And those were mostly in the pediatric population. But again, I think patients that in the adult arena that also are at risk, post-surgical, pre-surgical, or for other types of things that are being brought into the institution, maybe in an OBS unit that aren't in an ICU setting, that we don't think about routinely monitoring continuously, may actually benefit if we believe some of the literature, both from the adult, neonatal, and pediatric arenas. So we're going to kind of shift topics here a little bit and talk about looking at another mechanism of taking that technology and utilizing a different aspect to take a look. As most folks know, clinicians know, that pulse ox is more than just the numbers, and that the pleth waveform is a vital component to this type of monitoring. And this is a short synopsis of some recent interest in some recent publications that really look at what is referred to as the pleth variability index, or PVI, which is basically a new algorithm allowing automated and continuous monitoring of respiratory variations in the pulse oximetry pleth waveform amplitudes, and trying to use that to determine patients that are intubated on mechanical ventilation in the ICU that may actually be fluid deprived or may actually potentially respond to fluid boluses. And again, it could be invasive or non-invasive mechanical ventilation while they're being sedated or anesthetized. And a lot of the work is coming out of the OR areas, but there is some interest in looking in the ICU, and I have 3 studies here that have been recently published in the last year and a half or so that really took a look at this technology and this algorithm built to help determine the potential benefits of fluid resuscitation. So the first one is from DeSaab and colleagues that looked at the ability of the PVI to predict hemodynamic effects of PEEP in those patients undergoing mechanical ventilation and general anesthesia. And what they actually determined is that PVI may be useful in automatically and non-invasively detecting hemodynamic effects of PEEP when tidal volume is at or above 8 milliliters per kilogram in a ventilated sedated patient, and it had a pretty good sensitivity and specificity. So as they're manipulating, looking for PEEP of best compliance and PEEP of best oxygenation in these patients, they actually were able to really determine the hemodynamic effects of PEEP in these patients and optimize that based on this PVI index, if you will. Some other groups, Zimmerman and colleagues, basically looked at the accuracy of stroke volume variation compared to PVI in the ability to predict the need for fluid responsiveness, or the ability to predict fluid responsiveness in patients undergoing mechanical ventilation and for major surgeries. And what they found out is, if you look at the old stroke volume variation versus the PVI, that they both serve currently as valid indicators of fluid responsiveness in those patients undergoing major surgery that are receiving mechanical ventilation. So again, the ability to now not necessarily draw blood and analyze it and do calculations, but to really look at the variability in the pleth waveforms to determine if a patient actually is in need of fluid, and if they're in need of it, actually determine if they actually respond nicely to it. So the final study by Lupick and colleagues looked at the ability of the PVI to predict fluid responsiveness in the ICU. So they got it out of the OR setting and they looked at it strictly in the ICU setting, and again came to very similar conclusions as their colleagues did, that PVI can predict fluid responsiveness non-invasively in the intensive care units in these patients undergoing mechanical ventilation. So again, some different twists looking at not just the numbers now and specific saturations, but really looking at an algorithm based on PVI and its ability to help them determine if patients would respond to fluid or are in need of fluid to begin with that are undergoing mechanical ventilation in the ICU or during surgery, but also looking at how the cardiac output and the cardiac criteria, if you will, respond to a PEEP of best oxygenation or compliance. So again, some interesting ways to look at existing technology in a different format. Also, from the same standpoint, in people's desire to move from episodic monitoring into a more definitive diagnostic arena, or at the very least as a functional screening tool, has led pulse oximetry into other areas. So the first area we're going to kind of touch on is sleep. We're going to look at some kind of concepts from pediatrics as well as some from the adult arena that really look at obstructive sleep apnea, and can this be used maybe not necessarily as diagnostic, but at least as a screening mechanism for patients that are at risk or suspected of having obstructive sleep apnea. So this is, both these studies are several years old, but it hasn't become commonplace, so that's why I think it's still a topic and an area of debate today. This is found in pediatrics, and it really looked at nocturnal pulse oximetry as an abbreviated testing modality for pediatric patients with obstructive sleep apnea. So these were basically 349 patients that were referred into a pediatric facility to take a look at obstructive sleep apnea. And so kind of they brought them in a night before. They actually put them on continuous pulse oximetry to try to identify if this could be an effective screening measure for some of those patients without needing a true full sleep area, or if they could, or sleep study, or if they could potentially eliminate some patients from going through a full sleep study that really did not have any obstructive sleep apnea. So when you take a look at it, they got some traditional waveforms, and again, since this was all continuously monitored, it was downloaded. You can go in and look at it. You can manipulate the data. You can take a closer look at specific sections to see if it's artifact versus a reality. And you really kind of come across four typical types of waveforms, if you will. So the top waveform is really one that is interpreted as an OSA negative trial, because the patient saturations are pretty consistent with moderate fluctuations, but no major desaturations. The middle two are both identified as obstructive sleep apnea positive studies, because we can see some desaturations, if you will, in both of these patients. The first one, or the second graph there, if you will, shows some major desaturation, some as far as 70% and into the 60s, of a patient that definitely had some obstructive sleep apnea, and definitely indicated that this patient was at risk for untoward events from OSA. The second one, while not quite as demonstrative as the previous one, the third one does show this patient also experiencing periodic desaturations, and was also interpreted as OSA positive. And again, desaturations that were falling into the 80s, and one there right about in the middle of that graph that is actually probably in the high 70s. So again, the ability to do continuous monitoring as a screening mechanism looking for OSA in pediatrics was definitely determined possible. I'll show you some of the specifics from the study. The final waveform really is one that's inconclusive, because while it seems to have some fluctuations, it does seem to have some desaturations, there's a lot of noise in that signal, and really just not determinable from pulse oximetry continuous monitoring, and those patients definitely should go on to have a true sleep study. So what did the data show? Well, the data actually, as these patients actually went on from kind of this screening mechanism into full-fledged sleep studies, showed that 210 of those patients, if you will, actually, or 60% of the original 349, had obstructive sleep apnea as defined by polysomnograms. Now, when you look at it, 93 of those patients tested positive for OSA just in a sleep study based on continuous oximetry. And again, not too bad as a generic screening tool, if you will. Of the remaining ones, 256 were classified as either being negative or inconclusive. They really couldn't tell from those sleep studies. But it had a relatively decent correlation factor, an R2 value of about 0.78. So again, not meant for diagnostic purposes, but kind of placed there for at least a screening mechanism. And Brulette and colleagues went on to say that positive oximetry trended with a likelihood of about 20 patients to find one that was identified by pulse oximetry, but it increased the OSA probability from that 60% up to 97% of those patients. So of those that screened positive with a continuous pulse oximetry monitoring for OSA, when you actually did sleep studies, 97% of them were right on. And in fact, they went on to say that 90 of the 93 actually had very severe obstructive sleep apnea. When you look at the negative or inconclusive oximetry, the result had a likelihood ratio of 0.58 and decreasing the probability of OSA from 60 to 47%. So again, it did screen out some of those that were truly negative, that really had no indications of obstructive sleep apnea. They could be easily identified in that screening mechanism so that they wouldn't have to go on to a full-fledged sleep study. Is it ready for prime time? Probably not. Since this was done in a couple different children's hospitals, they felt that the inter-observer oximetry reliability was pretty good to excellent with a K value of 0.8. But it is a kind of a crude screening mechanism if you have patients that you're somewhat concerned about for OSA, as opposed to going for a full-fledged study. And again, those that deal with reimbursement know that if you have somebody in the hospital, if you do a sleep study before they're discharged, most of the time it's not reimbursable. However, you can do a continuous oximetry with a download and look at it as a screening mechanism. Those are typically reimbursable. And if you have something that's inconclusive or questionable, then the patient can be discharged and scheduled to be brought back for a sleep study to get a more definitive diagnosis. So again, this was really kind of set up as a screening mechanism in a pediatric population. Flipping over to the adult world, very similar results found in this study by Netzer and colleagues in the adult arena. They went on to show that overnight pulse oximetry is a very useful tool for diagnosing sleep disordered breathing, that they felt that it was a cost-effective screening mechanism for OSA that shows substantial accuracy in an adult population. They went on to say that the sensitivity and specificity remain somewhat controversial, which will require further controlled studies. But again, they suggested a mechanism to delineate clinical use of overnight oximetry as a screening tool for OSA could be a vital component for patients that may not be caught otherwise. So this was kind of a hodgepodge of patients. It was patients that were identified potentially as having OSA or meeting the criteria of OSA. These were some patients that were coming in for preoperative monitoring before surgery. And so this was kind of a little bit of an all-comers in an adult world. But again, the mechanism was to take a look at using this for screening patients that were at risk or suspected of having OSA in adult population. So while it's not diagnostic, polysomnograms continue to be the diagnostic gold standard, if you will. This is a mechanism to look at patients that are potentially at risk both in a pediatric and an adult arena that are at risk for OSA or have some high signs, some clinical valid indicators in a history that may indicate that there is some sleep apnea potentially present, to either screen them definitively into a sleep apnea category or that may actually lead to a highly suspected diagnosis that would lead on to further polysomnograms. So kind of sticking with that screening mentality, but shifting focus a little bit from OSA screening to a new initiative for congenital heart disease is something that's really starting to take hold, and we've got our own personal experience here as recently as in the past week, and I'll kind of come back to that. If you look at the United States, about 1% of all live births are diagnosed with congenital heart disease, of which about 25% have a serious defect. And so that has led a lot of people to trying to take a look at, can we provide a more timely recognition and diagnosis of congenital heart disease? Now this is a study that comes from the OB-GYN world, if you will, and it really looked at how congenital heart defects were diagnosed in a specific institution. And while it is a somewhat smaller number of patients randomized into this trial or in this trial. I'll show you another slide from a larger trial in the European sector of the world that actually indicates very similar results. But what these authors went on to show that about 23% of the time there is a prenatal diagnosis of congenital heart disease. About another 11% or so are caught at birth. So after the baby is born, something isn't quite right. The baby may be dusky, may not be saturating. They get an echo or something of that nature. And about another 11% of the time, we actually diagnose congenital heart disease. If we take those two figures and put them together, 23% and 11% tells us only about 33% of congenital heart diagnosis are actually identified either prenatally or at the time of birth before these children are sent home. That can be very problematic. And in this very small study, the authors went on to say that another 39%, 7 of the 18 they looked at, are actually diagnosed with a congenital heart defect at a subsequent admission or readmission, if you will. So still, we're only talking slightly above 2/3 to maybe 3/4 of the patients, either prenatally at the time of birth or with a follow-up or subsequent admission, are being diagnosed. We're still missing 25%. Now, the 67 to 75% that are diagnosed in this window tend to be those at the top of the list. If we look at it, it's probably a little hard to read, but it's things like the hypoplastic left heart syndrome babies, the truncus babies, the pulmonary atresia babies, potentially the coarcs, total veins, VSDs, ASDs. Those that don't mix a lot or have a relatively low mixing basically are the ones that sometimes fall into that 25% category that go sometimes many years before they're diagnosed. But again, this kind of indicated that if we're taking a look at this and only about 1/3 of those children are being diagnosed with congenital heart disease before they're sent home, that's a potential problem. And the reason for that is if you look at the data from the next slide here, it actually tells you that in a different study, this looked at patients that were actually coming in with undiagnosed congenital heart disease. There were 51 of them, and about 50% of these patients appeared in severe shock on admission because their diagnosis had not been made, they'd been sent home, and then somewhere subsequent to discharge after being born, they ran into a lot of problems. So failure to diagnose critical congenital heart disease can be very problematic because if it's missed prenatally or at birth and these children are sent home, they typically come back very, very sick and in a high degree of shock and actually end up suffering a lot of morbidity and mortality at higher levels than they should because this wasn't diagnosed prior to them being sent out into the real world. So that has led some to suggest that potentially we should take a look at pulse oximetry screening in these babies. And so here's a study from a few years back that demonstrated that simple pre-post ductal pulse oximetry has both a high sensitivity and a high specificity after 24 hours. So high sensitivity, not only does it identify those that truly have the disease, but after 24 hours when kind of some of the ducts start to close and babies should have actually normal, what we would classify as adult circulation, you know, these babies actually have a very low false negative report. If you just actually slap a pulse ox on an upper extremity and one on their foot, you're actually able to catch a fair amount of congenital heart disease in that format. And in fact, if you look at some of the European data here that I alluded to earlier, this is over a number of years, 4 to 5 years, I believe. And Granelli took a look at this, and there were about almost 38 to 39,000 patients that were actually examined that also had pulse oximetry, and then they looked at the combined assessment of pulse oximetry and physical examination. And what they actually found in this study was that there was an increased sensitivity and specificity when you combine not only the physical exam with pulse oximetry, and that the false negative was about 2% or less. So they were able to identify at a very high specificity, 97% sensitivity in the high 80s, of patients that had congenital heart disease by just doing a thorough physical exam and doing pre- and post-ductal screening. So what that's basically led to is kind of an initiative, if you will, really looking at pulse oximetry in the feet, detecting a high percentage of duct-dependent congenital heart lesions, and really they feel that in addition, it's really easy to use, it's reliable, and it's cost-effective. So that has led a number of groups now, recently, the American Academy of Pediatrics and the American Heart Association in recent publications, to really promote the use of pre- and post-ductal saturations at birth prior to discharge to help screen for congenital heart disease. I can tell you that we actually have implemented this protocol just a few months ago, and we actually in the last week have caught 2 patients with very critical congenital heart disease lesions that were not diagnosed prenatally, but were caught soon after delivery before the child was sent home. And actually, we actually discussed this at one of our community hospitals last week. They implemented the protocol on Friday, and they have also detected a child that was shipped to us earlier this week with a severe congenital heart defect lesion that otherwise looked fairly normal at birth, and they were preparing to go home, and they did a pre-post ductal oximetry measurement, found a large deviation in the saturations, pre-ductal versus post-ductal, and sent the baby to us to be diagnosed with a congenital heart lesion. So again, not only looking at existing technology, but potentially looking at populations at risk in a screening mechanism may prove very valuable and beneficial from a quality and safety standpoint. We're going to shift gears here again a little bit now and talk a little bit about different types of oximetry that have arrived on the scene here in the last few years. We're going to start off with co-oximetry, and generally we're going to kind of focus on the monitoring of non-invasive hemoglobin, carboxyhemoglobin, and methemoglobin in these sections. So let's start with hemoglobin. This is a study by Fasca and colleagues that really compared non-invasive co-oximetry to laboratory reference values and said that the hemoglobin measured with co-oximetry not only was accurate and pretty close to those absolute values that they got from the lab, but they felt in addition that it provided the advantages of continuous measurements and it was done non-invasively. So hemoglobin seems to be becoming a potential possibility as a standard out there that you wouldn't have to do blood trials. A lot of it's based on a number of studies. Here's one that has demonstrated, at least in neonates with hemoglobin levels between 12 and 18 grams per deciliter, that it provided an acceptable accuracy and significant correlation between non-invasive and venous hemoglobin measurements. It said it can be performed reliably in patients in the intensive care unit setting in another study, and they went on to say that it has acceptable accuracy with a similar bias and lower standard deviation than a widely available point-of-care total hemoglobin testing device. So co-oximetry, as an addition to pulse oximetry, seems to have a pretty good correlation and accuracy when you're looking at hemoglobin in a normal patient population or a patient in the intensive care unit setting as being a pretty good measure of their hemoglobin as it would be referenced to the lab values. When we look at the general thought process behind the accuracy of pulse oximetry, if you will, there are certain conditions that we've always been aware of that actually can distort your pulse oximetry readings. And the 2 highlighted there in red have been such a problem over the years that groups have gone at looking, can we do co-oximetry in a non-invasive fashion to identify carboxyhemoglobin and methemoglobin in patients as opposed to running the risk of missing the diagnosis or sending them to the lab. So if we start off with carboxyhemoglobin, we look at it, we know that it has a 200 to 250 greater affinity for hemoglobin molecule than oxygen. So what it basically does, it goes in there and gobbles up the sites, if you will, and prevents oxygen from loading onto those sites. The problem is that when you look at light absorption, carboxyhemoglobin cannot be distinguished from oxyhemoglobin by pulse oximetry, and therefore you may have a patient presenting with higher saturations than they really look at. The next slide is just kind of a chance to hit both areas, that both either from a carboxyhemoglobin or a methemoglobin, that when these abnormal hemoglobins, if you will, are present on red blood cells, they create an inaccuracy. So, what types of patients are we really kind of talking about? Well, if we look at carbon monoxide poisoning patients, they're the leading cause of poisoning deaths in industrialized countries. People go on to say that even a single exposure has the potential to induce long-term cardiac and neurocognitive psychiatric sequelae, and that about a third to 50% of those patients that are exposed to CO2, carbon monoxide, are missed at initial diagnosis in the emergency department because we don't think to draw blood to send off for potentially a carboxyhemoglobin level, and because we don't have non-invasive monitoring, we don't think about it. So, that's led to some interest in research in those areas. Here's a study by Barker and colleague that really led to non-invasive methods to quantify abnormal hemoglobin. What he basically did is got volunteers and exposed them to carbon monoxide and methemoglobin using an 8-wavelength pulse oximeter designed to measure both of those devices as well as usual measurements of hemoglobin saturation and pulse rate. And what he did is he basically looked at the typical rates you would see from a carboxyhemoglobin 0 to 15% or a methemoglobin of 0 to 12% for their accuracy. And as you can see there in the results section, that he felt from a carboxyhemoglobin standpoint, it was plus or minus 2%. From a methemoglobin standpoint, it was within about 0.5% of those measured values in the lab. So pretty accurate, if you will, when you take a look at this, at least in a kind of a controlled clinical trial of normal volunteers. Kaboot and colleagues looked at it in a similar fashion, except they looked at it in a real-life setting. They looked at it as an ability to evaluate accuracy and reliability of measuring both carboxyhemoglobin and methemoglobin in 50 children with sickle cell disease. And what they went on to determine is that the co-oximeter bias was about 0.1% for carboxyhemoglobin and about 0.02% for methemoglobin, that it was pretty precise, and that while it slightly overestimated invasive carboxyhemoglobin and slightly underestimated invasive methemoglobin, it puts you within an area of measurement accuracy error that they felt pretty comfortable that, at least in the sickle cell disease population, they could identify those patients that potentially had high levels of carboxy or methemoglobin non-invasively without doing a lot of blood draws. So what about methemoglobin? This is a study by Feiner, who actually kind of looked at it in a unique way. That, again, they took some patients and volunteers, and what they basically did is actually gave them a low exposure to methemoglobin and made them hypoxic, and then they actually gave them a high exposure to methemoglobin and also made them hypoxic. And what they actually found from their results is, if you take a look at this, is you see a much bigger scatter on this diagram, if you will. And what they're basically stating here is that once your saturations, actual real saturations, fall below 95%, that the ability to do this sometimes in a hypoxic state to measure actual carboxyhemoglobin or methemoglobin becomes a little bit scattered and a little bit difficult. And they felt that it overestimated true values sometimes by as much as 10 to 40%. That elevated methemoglobin causes pulse ox readings to underestimate the saturation, similar to conventional monitors, and that the readings of both types of the instruments tend downward during hypoxemia, less than 90%, with methemoglobins on the higher end. So if we're looking at the graph, the more desaturated you are and the higher your methemoglobin level is, the more inaccurate the monitor becomes. As you come back to a more normal range of saturation or up at the higher end with a relatively lower methemoglobin area, your saturations and the accuracy of these monitors are pretty good. So again, technology that continues to be looked at, continues to be brought into the clinical setting, and potentially is very helpful in managing patients, diagnosing, screening patients that otherwise may be missed. So I'm going to kind of finish up the carboxy component with 2 emergency room studies that have been recently published before we shift to the last type of monitoring. So here's a relatively large study of all comers coming into the emergency room by Roth and colleagues that basically threw them on a co-oximeter to take a look at the risk or potential or screen them for carboxyhemoglobin. And what they found out is about 17 of those patients actually, or about 1%, actually received the diagnosis of CO poisoning. The upper limit of normal cutoff was about 6.6% for carboxyhemoglobin, and it had high sensitivity in screening for it. The bias was relatively low, the precision was pretty good, and they felt that this multi-wavelength pulse oximeter found to measure carboxyhemoglobin was within acceptable bias and precision. So again, just as a routine screen for patients presenting, all comers in the emergency room, they were able to potentially identify patients that had carbon monoxide poisoning. And if we go back to one of the earlier slides, there are indications from years of data that show that potentially a third to as many as 50% of those patients are not identified. So of course, I mean, I think anybody that's in a house fire, smoke inhalation, those types of things, or other types of things that may be self-inflicted, people sometimes quickly identify and they're going to measure for it. But other patients that are found somewhere that are unresponsive, that maybe someone doesn't know why they're unresponsive, those are the patients we tend to look at a lot of other things things, but don't think of CO poisoning, and potentially as a screening mechanism from that standpoint. A second emergency room study looking at carboxyhemoglobin, and again, a large one, all comers. About 11,000 patients received screening for carbon monoxide poisoning. And what they found out is that there was some interesting data that spit out in a large population. Some of their patients came in with about a 5.1% analyzed carbon monoxide content, where most of the others came about right around 3, or about half of that. And what they were able to do is, through their questionnaire and their study, is that they found out that people that were smokers actually have a higher resting value of carbon monoxide when you measure it, and it was able to detect that. So, this is really looking at CO poisoning in the emergency room, but, one may speculate, and really didn't do a lit review, is this something that potentially could be looked at from a smoking cessation or tobacco use standpoint down the road, if it is able to fairly precisely and accurately screen out smokers from non-smokers. I mean, that's just a thought theory, but in this study, again, they did have about 11 patients present with signs and symptoms not consistent with carbon monoxide toxicity that were identified through their screening, and they felt, again, as a mechanism of screening for CO toxicity, this non-invasive co-oximeter can be used to identify patients with occult CO2 toxicity. So again, another potential mechanism in an emergency room to look at non-invasive monitoring of carboxyhemoglobin, methemoglobin, even actually testing patients for normal hemoglobin in this co-oximetry monitoring that may lead us to some interesting places down the road. So I want to take the last couple minutes to finish up with some new technology that is moving from the OR setting into the ICUs. And again, if we just briefly go back and look at pulse oximetry, hypoxia is a failure of normal tissue oxygenation, where hypoxemia is a failure of normal blood oxygenation. So hypoxia basically refers to cells that are starved of oxygen, while hypoxemia refers to a low content of blood or a low oxygen saturation. And it gets back to that functional versus fractional, if you will. So basically, a patient can be hypoxic but not have hypoxemia. For example, in poor circulation, where they're well oxygenated, but the circulation is insufficient to distribute that oxygenated blood throughout the system, and this will result in a circulatory hypoxemia, although the pulse ox will show near 100%. So that has led some folks to really want to take a look at this more closely. We know that hypoxia can develop very rapidly, and in fact, if we take a look at why a pulse ox potentially has a slow response rate, if you will, it's basically because we're measuring in the periphery, and because the oxyhemoglobin dissociation curve, it tends to be a little bit slower in its response because of the shift in that curve. So that has led a lot of folks to have a renewed interest in arterial versus tissue oxygen hemoglobin saturation. And while they're related, they're a little bit different, because one is supply, the other one is demand. So while in the clinical arena we often put an emphasis on O2 supply by looking at blood gases, pulse oximetry, and defining interventions to help on that supply side, we can fix the SpO2 number a lot of times, but sometimes that regional perfusion or that arterial venous difference is more important at the tissue level, and it's not about the number on the arterial side, if you will, because arterial O2 doesn't guarantee tissue O2. So while there really is no absolute number from a venous saturation standpoint or a target, SvO2 depends on a lot of things. Blood flow, perfusion, if you will, pH, 2,3 DPG, the hemoglobin form, the concentration, and you can see the list up there. Again, what it's really indicating is that arterial hemoglobin saturation does not guarantee sufficient O2 delivery. So some people are becoming more and more interested in what is delivered to the tissue. So be it cerebral or regional monitoring, here's a form with NIRS, near-infrared spectroscopy, that actually uses the same Beers-Lambert law, if you will, that takes a look at monitoring regional saturation of gray matter in the brain if it's cerebral monitoring. And again, in that area, it's 75% venous, 25% arterial, and this data that's collected is displayed about every 4 to 5 seconds. What does it measure? Well, regional hemoglobin oxygen saturation in tissue under the sensor is what is measured. It's venous weighted, and while there's really no standard, it's really kind of based on flow and metabolism being coupled together, a question of delivery versus consumption, if you will, and it reflects perfusion distribution. It's felt, and again, I'll show you a slide here in a second, that in healthy levels, that regional saturation typically is somewhere about 60 to 80% in a normal adult population. Why is that important? Because it relates, at least if we're looking at the brain and cerebral perfusion, back to cerebral blood flow is really dependent on CO2 and oxygenation, and there's a linear relationship there, as well as temperature having an impact. And for every 1 degree decrease in cerebral metabolic rate, it decreases 6 to 7% in the saturation. So hence the interest in cooling in patients that potentially have head injury or are undergoing surgical procedures or are having issues with hypoxia, because you can manipulate cerebral blood flow. Listed on here a lot of considerations and potential interventions, but what I want to really do is kind of focus as we wrap up on the technology, because it's relatively new. It's mainly been in the OR, but it's starting to creep out into the ICU. So here is a study from over a decade ago that really looked at the technology, and what it was trying to do is determine if it is accurate and if it's valid. And what they found out is in these 30 patients that it was pretty linear and pretty correlative if you could measure samples from the areas. And again, it was pretty much a very valid way of doing it. And if we go to the next slide here, we can see that it had a very high sensitivity, pretty accurate, pretty precise, and pretty reflective of what was going on if you measured it. High sensitivity of 97% if you do the calculations, with a very small bias and a very low standard deviation. So a good mechanism to look at cerebral or regional perfusion and saturations, if you will. This is the slide I alluded to earlier. If you look at based on either skin color, male versus female, or if you throw all comers together in this study of 225 normal saturating ambulatory adults, the range typically is somewhere between 60 and 80%. So that appears to be kind of what we're relying on as a normal level for this regional monitoring. This is some data in the next couple slides looking at pediatrics. And in fact, this one actually is not pediatrics. The next two after this are pediatrics. This is an adult cardiothoracic population, almost 100 patients undergoing cabbages, if you will. And basically what they were looking at is the ability to use regional saturation monitoring to determine if they needed to increase perfusion pressure, the pump flow, FiO2, if they felt that the patient was becoming having low hematocrits, or if they actually had CO2s that were increasing that potentially were actually decreasing their ability to saturate and perfuse the brain. They also looked at temperature as a value there. And what they found out is that when they used these interventions based on the saturations in this adult cabbage population, that they were able to actually greatly decrease their overall length of stay by keeping their regional or cerebral perfusion, if you will, in that 60 to 80% range, versus those that weren't monitored tended to have a little bit longer length of stay. One kind of adult study, but validated in a lot of pediatric studies. And again, the typical range from a cerebral standpoint in a pediatric population seems to be about 60 to 80, assuming that your saturation arterial is normal at 90% or above. And they've gone on to say, if you look kind of right there in the middle of the screen, in this area here, that if you're in the kind of the mid part of that, or you have a 20% change from your baseline, that probably is problematic. And if your regional perfusion is less than 45% with more than a 25% change from baseline, that becomes a critical threshold. That work kind of comes out of looking at hypoplastic left heart syndrome. So I'm going to show you those two studies really quick, and then we're going to wrap up kind of some of the theories behind regional or cerebral monitoring that really has led to some increased interest. So here are hypoplastic left heart syndrome patients that were looked at preoperatively and postoperatively from a Norwood procedure, and what they saw in 22 in looking at 22 patients, that about a quarter of them actually had ischemic lesions prior to post-op, and that actually increased up to 73% post-operatively after undergoing a Norwood, which is a pretty extensive cardiac repair procedure, and that PVL and focal ischemia lesions are the most common. And what they actually found out is those results came from patients that had prolonged low post-operative regional perfusion for at least 2 or 3 hours, were associated with a higher risk of new or worsened ischemia post-operatively. So that actually led to a more randomized prospective trial from Phillips and colleagues that looked at using regional cerebral perfusion in the OR during these procedures. And what they basically did is those that they kept in what they felt was a normal range had a significantly higher, better outcome. And outcome was defined as hospital death, need for ECMO, or cardiac intensive care unit stays greater than 30 days. Those that were kept in a normal range had far better outcomes than those that actually were allowed to sit on the lower end of normal or slightly below normal. So again, I think there is some increasing interest in using this monitoring capability outside of the OR. When we look at key study findings from the adult surgical ICUs, it's been shown to improve outcomes, decreasing major organ morbidity and mortality, fewer severe oxygen saturation, shorter length of stays in the ICU in the hospital. It's in one study showed improved outcomes in diabetics, and also shown a ability to reduce incidence of stroke and prolonged ventilation. Pediatrics, low perioperative death. Trends approximate the venous oxygenation trends, less renal problems, less ischemia problems by mechanical obstructions, either in ECMO or CT surgery. Neonatal, potentially something for ECMO again, help managing hypoxia in ventilated patients, reliable monitoring over extended period of time, and immediate results of PDA ligation for oxygenation. And finally, some areas and thoughts: traumatic brain injury, potentially, life flight or ambulance transport, neuro ICU, aneurysm repairs, and sleep apnea are some areas that are currently being looked at. So again, I just wanted to touch upon a multitude of areas. I know we've kind of gone long, but I think these are some interesting opportunities for non-invasive monitoring in the
Tim,
RRT
I want to thank
community.
you very much. It was a most interesting discussion about innovative adaptation of pulse oximetry to aid in diagnostics. We are just about out of time, but I do have a couple questions here that have come in during the presentation. One person wanted to know, how do you account for vascular insufficiency to a limb or area when using the PVI?
So again, I think, you know, if we take that question and we flip back to this cerebral region perfusion monitor, again, the question becomes a difficult one if we're really trying to determine if it's O2 content versus delivery. So we may get very confused if we're looking at content, because saturations can be very high. But if we have abnormal blood flow, then our tissue is going to be starved of oxygen, and that potentially becomes very problematic. The PVI index is something that is still relatively new, only found it across about 3 or 4 studies. So I think it needs a little bit more work. The studies that were published seem to be in patients that had what we would refer to as normal O2 content and delivery. They weren't at patients that were at high risk for tissue delivery issues. So if you've got perfusion problems, it could be problematic and it may not work.
One person wanted to know, if someone uses a finger probe for other than finger monitoring, can be is it still can be? They state that it can be inaccurate, like using it for the ears or somewhere like that. Is that true? Can you comment on that?
Yeah, I mean, again, I think that probably each manufacturer is going to be a little bit different. But I think, you know, if we just think about the disposable probes, if you use the wrong size probe, and it may have a negative impact on the way light absorption is delivered and read. So I think if you're trying to use probes that aren't designed for the areas you're using them, or you're using them in an inaccurate size, you actually stand the risk of increasing that 2 to 4% error range that we saw in a normal saturated patient.
Okay, and one last question. It's a simple question. How long do you keep the oximeter on before the baby is discharged?
So I think if you're referring back to the congenital heart defect patient, basically it is a simple, you know, 5 to 10 minute screen. You place a preductal probe on, you put a postductal probe on their foot, and if you end up with a larger gradient than normal in a patient that seems to have relatively well perfused hands and feet, for example, then you have to highly suspect that this patient may have congenital heart disease. Now, why it's not diagnostic, it's screening, and those patients that have a large gradient pre versus postductal then go on to have an echocardiogram prior to discharge. So again, very similar to the obstructive sleep apnea. It's a screening tool for patients at risk of a potential defect or problem that you may not identify otherwise, that is relatively quick and inexpensive to do.
Again, Tim, thanks a million. We've got to get going. We're at the end of our program today. For those of you watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRCE contact hour. If you're watching this as a program as an archive, this concludes our presentation.